to the end.
Yeah. All right, we'll give it one more minute. There are some sign-in sheets at the centers of every row. And so if people could sign in and make sure we have your email address and your committee affiliations within SWOG. And for those of you who are logged on remotely, if you would be willing to just put in the chat, we can see who you are logging in. So you don't necessarily have to put your name, but just put your disease affiliations. In the AYA committee, of course, we have liaisons to all the other committees, and some of those have fallen off either through COVID or just because of people changing their affiliations within the disease committees in the past couple of years. And so if anyone would be interested in representing AYA on their own disease specific committee, please let me know after the meeting, and whether or not that's a specific role that you're looking for, just let us know your affiliation on the sign-in. All right, so we'll go ahead and get started. Happy to welcome you today to the AYA meeting. I'm Becky Johnson, and we have my Vice Chair, Lucia Nappi, attending remotely today. And then we've got a nice list of speakers for you. First of all, also attending remotely will be Dr. Kimmy Eng from the Dana-Farber, who is going to talk to us about her recent work in AYA colon cancer epidemiology research and the program that she's built at the Dana-Farber to serve these patients. And then on the flip side of that coin, our AYA patient advocate, Allison Rosen, is going to tell about her experiences as an AYA colorectal cancer patient, and also talk about shared decision-making between colon cancer patients and their physicians. And then we are honored here to have John Saltzman discussing his intergroup AYA PRO trial, and we'll have some time for discussion and questions regarding that ongoing study, and then some questions and answers at the end. So Dr. Eng.
Yes, thank you. Thank you so much for, can you guys hear me?
Yeah, we can hear you great, and I'll advance your slides for you.
Perfect, thank you. So thank you all for the invitation. I am really happy and honored to be here to tell you a little bit about the work that we're doing in young onset colorectal cancer. I am an adult medical oncologist in the GI division at Dana-Farber Cancer Institute, and I founded the Young Onset Colorectal Cancer Center there. Next slide. So these are my conflicts of interest, which aren't directly relevant to the content of the talk. Next slide. And this is a basic outline of what I'll be going through. I'll review some of the background statistics and trends regarding colorectal cancer, talk a little bit about our program that we've developed at Dana-Farber, and then go into some of the epidemiologic studies that have been done to try to understand the underlying etiology of the rising trends of this disease in young people, and then end with some ongoing and future research efforts. Next slide, again. So for those of you not as familiar with GI cancers, colorectal cancer is a major problem in the United States. It is again estimated to be the third most common cause of cancer in both men and women, with nearly 150,000 new cases expected in 2022. Next slide. It is also one of the top causes of cancer death, unfortunately. When you combine men and women, it is actually the second leading cause of cancer death after lung cancer, with nearly 50,000 deaths expected in this upcoming year. Next slide. Fortunately, if you look at the graphs on the bottom, incidence rates have been declining nicely for those over the age of 50, which has historically been the screen eligible population. You can see here for several decades now that incidence has been decreasing in both men and women. But if you look at the curves at the top, in people under the age of 50, you can see that after a period of decline and plateau, there has been a steady approximately 2% per year rise in the incidence of this disease in young people. And it's occurring for both men and women and for both colon and rectal cancer. Next slide. And interestingly, although there are well-known disparities in the incidence and mortality of this disease by race and ethnicity, the steepest increases in young onset colorectal cancer are actually happening among non-Hispanic whites, among both for both colon and rectal cancer. There is a slight increase in rectal cancer among non-Hispanic Blacks as well as among the Hispanic population, but by and large, the highest rates have been in non-Hispanic whites for reasons that are still unclear. Next slide. This is also a phenomenon that is not just happening in the United States, but actually globally. You can see on the curves on the right, for countries that do have institutionalized screening programs, those 50 and over have, like the US, experienced declines in the incidence of this disease in older individuals. But there has been a rise in younger individuals, predominantly in higher socioeconomic status countries. Interestingly, there have been stable trends reported in the Mediterranean and Far Eastern countries, which certainly is intriguing given that diet and lifestyle are strongly implicated in this disease. Next slide. And unfortunately, this increase is not isolated in time either. Modeling studies estimate that this is expected to continue to increase over the next decade, such that by the year 2030, nearly 11% of all colon cancers will be occurring in people under the age of 50, and almost a quarter of all rectal cancer cases will be happening in these young individuals. Next slide. And other interesting patterns have started to emerge that suggest that young onset colorectal cancer may not be the same as older onset colorectal cancer. It's predominantly left-sided cancers that are occurring in these young people. You can see in these graphs here that for the blue colon, you can see that only about 20% or so are from the sigmoid and the rectosigmoid, whereas in younger populations, nearly a third of all cancers diagnosed in young people are occurring on the left side. Next slide. And probably the most frightening of all these statistics is that we don't understand the underlying causes of these trends that we're seeing. Although it is more likely to find a hereditary syndrome or have a patient with a family history when you have a young person with this disease, the vast majority have no obvious risk factors, family history, or germline predisposition. Next slide. But we do have clues as to what might be going on, and they all suggest that this is likely not any shift in germline genetics. You can see that there is a strong birth cohort effect seen, where compared to the reference group of individuals born in 1949, those individuals who were born in 1990 have quadrupled the increased risk of developing rectal cancer and double the risk of developing colon cancer compared to people born in 1949. And this strongly suggests that it's recent changes in environmental exposures that are likely underlying the epidemiologic trends. Next slide. And not only is incidence increasing, unfortunately, mortality from this disease is also increasing in young people. In the graph in the bottom right-hand corner there, in older individuals, again, because of the success of screening programs, there have been steady declines in mortality among those 50 and over. But if you look at the graph directly above, among young people, there has now started to be an uptick in mortality from this disease in those ages 20 to 49. Next slide. And this is partially because young patients are diagnosed with more advanced disease. In a survey study of 1,000 young onset colorectal cancer patients, 41% waited over 6 months before seeking medical attention. And that's largely because cancer is simply not on the radar of somebody who's otherwise young and healthy with no family history or genetic risk. Next slide. When these patients did end up seeing a frontline provider, 67% reported having to see 2 or more physicians before being correctly diagnosed with colorectal cancer. And that is also because this disease is not on the radar of the clinicians seeing these patients who are otherwise young and healthy. Next. And so that means that 71% of this population of 1,000 young onset patients ended up being diagnosed with stage 3 or 4 disease, which we all know is much less curable than stage 1 or 2 disease. Next slide. We also have evidence, though, now that it might not just be delays in diagnosis, but also that it might be a more aggressive disease that happens in younger people. In this large study that compared 13,000 young adult patients to 37,000 older adult patients, You can see here, if you click next, that young patients more often received postoperative systemic chemotherapy, even when it was not necessarily indicated, and more often with multi-agent regimens compared to older adults. Next slide. I'm not showing this, but even though I'm not showing this, they even received more radiation treatment as well as more surgeries. But in the survival curve to the left, you can see that there is no corresponding gains in survival despite the more aggressive treatment that these young onset patients are receiving. And in the curve to the right, this is a series of about 600 young onset metastatic colorectal cancer patients from Memorial Sloan Kettering Cancer Center. You can see that although not statistically significant, the very youngest patients in the dark red, ages 14 to 35, seem to have the worst survival, with a median of only about 47 months compared to 55 months for those above the age of 50. Next slide. When we look at stage-specific patients with young onset disease, those with high-risk stage 3 colon cancer also seem to have a shorter time to recurrence compared to patients who are older at the time of diagnosis, as well as increased cancer-specific mortality. Again, suggesting that perhaps this disease is biologically different than older onset colorectal cancer. Next slide. And in a study, if you click again as well, in a study that we did using the Alliance CALGB 80405 clinical trial, comparing different biologics combined with chemotherapy in metastatic colorectal cancer patients, when we looked at outcomes by age of diagnosis, the median overall survivals of young onset patients compared to older onset patients was not significantly better than those who were older, despite the fact that younger patients received significantly higher dose intensity of the chemotherapy regimens and that they had less adverse events compared to older patients. Next slide. And so all of this has led us to do studies to understand whether there may be genomic differences between tumors that develop in younger people compared to tumors that develop in older individuals. In this study, looking at the Foundation Medicine database, you can see in the blue bars the genomic alterations in young onset patients compared to the orange bars, which were occurring in older patients. And there are some subtle differences, such as fewer APC mutations in young adults and fewer KRAS mutations. But overall, the differences are not that striking. So further work needs to be done to better understand what the biological differences are. Next slide. And this is also, very alarming, which is that CRC is estimated to become the #1 cause of cancer death in people between the ages of 20 to 49 by the year 2030, surpassing breast cancer as the leading cause of death in this young population. Next slide. Fortunately, the United States Preventive Services Task Force has started to take a step in the right direction in trying to reverse these trends, recently lowering the age at which to begin colonoscopy and other colorectal cancer screening tests from age 50 down to 45 for average risk individuals. And while this will certainly prevent more cancers in young people and certainly save lives of young people, the vast majority of whom are in their 40s when they're diagnosed with colorectal cancer, it certainly is not helping the very youngest patients in their 20s and 30s, where the rates of colorectal cancer are rising most steeply. So this really underscores the urgency of conducting the research to better understand what the underlying risk factors are so that we can come up with a high risk profile and identify the young patients who should be targeted for earlier screening. Next slide. And going back to these young patients, as we all know and are aware of, young patients do face unique challenges compared to older patients diagnosed with this disease. Because of the age range of our population with colorectal cancer, who are mostly in their 40s, the vast majority, 80%, again, in this survey of 1,000 young onset patients, have children under the age of 18 when they're diagnosed. They're also still having to work for their health insurance, and many experience career and education disruptions as they're diagnosed. There are high rates of anxiety and psychosocial distress. Many do require treatment for these conditions, and many have financial difficulties as well. What's not reflected here is that many are also taking care of elderly parents, because this is really the sandwich generation that is being affected by young onset colorectal cancer. So a lot of unique needs in this population. Next slide. And so for all those reasons, as we saw more and more young people coming in with advanced stages of colorectal cancer, we felt that there was a significant clinical and research need to develop a specific center focused on this young population of patients. And so there are a handful now around the world, but we do remain one of the few who are dedicated to this area. Next slide. So our Colorectal Cancer Center launched in March 2019 with a threefold mission. The first, clinical care to provide expert, compassionate, and comprehensive care to every young patient diagnosed with this disease who's seen in our center. The second, to raise education and awareness with the hopes of improving prevention and early detection. And then launching a multidisciplinary research effort as the third mission to really promote scientific discovery and innovation to develop, understand the risk factors and develop novel ways of screening and prevention as well as treatment. Next slide. So in regards to the first mission of providing multidisciplinary comprehensive care, every young patient, as with all patients at Dana-Farber, do receive a multidisciplinary evaluation. What we've instituted that's a little bit different for the young patients is making a germline genetics consultation appointment automatic and reflexively scheduled at the time of the first visit. We do feel that this is very important, even though the vast majority of these cases are not due to a germline condition. Because there are so many other factors that go into a young patient's journey with this disease, we also have fertility services, nutrition, sexual health, integrative oncology, all the other aspects that do influence a patient's cancer experience automatically offered to every young patient. Because there are high rates of psychosocial distress among this young population, our center does have a dedicated social worker with expertise in caring for young patients with cancer who has really done a great job customizing programs to meet the unique needs and gaps in their care and support as they go through their journey. We also have a dedicated program coordinator to act as a patient navigator of sorts, who is a liaison to both the clinical and research teams for these young patients, many of whom have not had experience in healthcare systems before this. And finally, we do believe in a personalized treatment approach where every young patient does get their tumor genomically profiled as a part of this program and their report reviewed by a multidisciplinary molecular tumor board that then matches their genomic profile to either off-label therapies or clinical trials that are going on at Dana-Farber. Next slide. And if you click just one more time, with the development of our center, we have really pioneered a new care model for our young patients that's different than an older patient coming in to be seen in our center. We've now implemented a psychosocial distress screen, which has increased the number of social work referrals and really normalized social work as a standard part of care for these young patients. And now we have pretty robust psychosocial programming offered to our young patients. Because our center launched right around the time of COVID, we were the first at Dana-Farber to use Zoom for support groups and patient events. And we've also been able to create new peer-to-peer mentor programs, many of which can be done virtually. And the benefit of this is certainly that not only do patients who are seen in our center, not only do they get to benefit from some of these resources, but this is available to patients beyond Dana-Farber as well. And these are just a few of the events that we have put on for our young patients over the last couple of years. Next slide. In terms of our second mission of raising education and awareness, one of the biggest things that we've heard from our young patients is that they feel isolated in their journey. The average age of diagnosis of colorectal cancer is in the late 60s or early 70s. So many of these young patients look around the waiting room and only see older individuals. And so one of the goals of our center is also to create a community for these young patients. And we do that in a variety of ways, including issuing a quarterly newsletter, which does spotlight patients and their experiences, as well as update on the latest research advances. We have an annual young onset colorectal cancer patient and family forum, which unfortunately has had to be virtual over the last 2 years. But we've had speakers like Dr. Ibram Kendi, who he himself is a young onset colorectal cancer survivor, as well as Craig Melvin this year, co-anchor of the Today Show, whose brother recently passed away from young onset colorectal cancer and who is a very strong colorectal cancer patient advocate. We also believe in raising education and awareness among the healthcare community, and so have started a quarterly webinar series called Gut Instincts, aimed at healthcare professionals to educate them about issues specifically related to young patients with this disease. And we now do have an international following on Twitter as well, to hopefully reach more healthcare professionals who are using social media to get their research news. Next slide. Colorectal cancer is a cancer that's not talked about very much. There is a stigma around this disease, partly which leads to less funding for this disease. And so, unfortunately, Chadwick Boseman recently did pass away from young onset colorectal cancer as well. But I do think his legacy is that he did spark a national conversation around this disease. And really, all the news coverage around his passing definitely has raised awareness among young people and among underrepresented communities that this is something that is increasing and more frequent in those populations. Next slide. And then finally, we're also working with government for advocating around, better coverage for colonoscopy screenings, as well as more funding for this disease, and have worked closely with NCI to help set their research and funding agenda around this issue as well. Next slide. And then finally, if you click again, I'd like to end with some of the research that we're doing. This is a complicated disease with multiple factors that are likely involved. And so this is the framework that we've been using to think about what the underlying biology might be. The first is that this is simply the same disease just happening for some reason at a younger age. And so the approach for that is to focus on known diet and lifestyle and environmental risk factors for colorectal cancer, and especially the ones that have changed in recent decades that might have paralleled the rise in this disease in young people. And then see if there's a biological mechanism there that might explain why this is happening. But there's a second possibility, which I've alluded to, which that this is a different disease in biology completely, which is a slightly harder question to study, where you have to really consider other recent environmental exposures that have not traditionally been associated with disease, and really look into whether it could be related. Next slide. So we have focused on the first possibility, utilizing the Nurses' Health Study 2, which is an ongoing prospective cohort study housed at Harvard here that enrolled over 116,000 healthy female nurses who were aged 25 to 42 at the time the study started back in 1989. These nurses are sent questionnaires every 2 years, asking about standard risk factors, diet and lifestyle, and their medical history. And in order to facilitate more translational epidemiology, many of them donated blood and urine samples at various time points, as well as stool samples during the course of the study. And because this is a healthcare professional population, follow-up rates are excellent in this cohort. Next slide. And so the first risk factor that we focused on that has clearly been rising in recent decades, and which is associated with colorectal cancer no matter what age you are, is obesity. And so we did find in this publication here that among these young, healthy women, those who did have a body mass index of 30 kilograms per meter square or higher did have significantly increased risks of developing colorectal cancer at an age under 50. And because we do think lifetime exposures are the most relevant factor here, starting from exposures in childhood and adolescence, when we asked about weight gain since age 18 years of age, those who did report the biggest gains in weight of over 40 kilograms had over double the risk of developing this disease at an age under 50 compared to those who did not gain as much weight over this time period. Next slide. But again, not all studies show the same association, and just anecdotally, the majority of our patients are not obese and actually live very healthy diets, follow healthy diets and lifestyles. And so clearly this is not the only factor. In this large database study from the North American Association of Central Cancer Registries, they tried to correlate obesity rates between 1995 to 2005 with colorectal cancer rates in the subsequent 10 years, and they found no significant correlation. Next slide. We also looked at another risk factor that's well known for colorectal cancer, which is sedentary behaviors, namely TV viewing time, because this particular sedentary behavior is often associated with other unhealthy behaviors as well. And certainly among these young women who reported more than 14 hours per week of sedentary TV viewing time, risks were significantly higher for developing young onset colorectal cancer compared to those who were less sedentary. And in the bottom chart here, when we looked at primary site of the tumor, colon versus rectum, there was a much stronger association with development of rectal cancer, which if you remember at the beginning of my talk, a lot of the young onset cancers that develop are left-sided and in the rectum. So this certainly adds to the biologic plausibility of sedentary behavior being a risk factor for this disease. Next slide. We've also looked at sugar-sweetened beverages, which also has certainly upticked in recent years, and found that those who consume more than 2 servings per day had, again, over double the risk of developing colon cancer at a young age. When we queried them about sugar-sweetened beverage intake during adolescence, the risk became even stronger, over triple the risk of developing this disease at a young age. And so certainly this is probably a very strong risk factor as well. And then next slide. We also looked at vitamin D intake from diet as well as supplements. Vitamin D does seem to have a significant role in the treatment of patients with metastatic colorectal cancer, less of a clear role in chemo prevention, but at least in this study among these young, healthy female nurses, those who were not consuming sufficient amounts of vitamin D from diet and supplements did seem to have increased risks of developing colon cancer under the age of 50, as well as polyps under the age of 50. Next slide. And so this is a schema in a review that we wrote in Nature Reviews Clinical Oncology, kind of outlining the ideal study, which, would be to follow people from, in utero times all the way through childhood and adolescence into adulthood, again, because these chronic lifetime exposures are likely contributing to adult risk of this disease. And then trying to collect, biologic samples along the way too. But this is not feasible. And so there need to be quicker ways to try to get at some of these answers if we are to develop some novel prevention and treatment strategies. Next slide. So click again. So what we are trying to do is we did launch a new prospective cohort study of young onset colorectal cancer patients along with our center called Beyond CRC, which stands for Better Understanding of Young Onset Colorectal Cancer. Next slide. And why do we need another cohort? For largely the reasons I mentioned, but also because there are still a very limited number of cases of young onset disease in existing contemporary cohorts, many of which have minimal racial, ethnic, and geographic diversity, which we really need to better understand in terms of the gaps that are well known in this disease. There often is a lack of comprehensive collection of stool specimens, for example, for microbiome analyses, and not great collection of diet and lifestyle factors that's validated in these cohorts. Many don't have good genomic correlates or suboptimal clinical annotation, and many don't collect specimens serially over time to understand the role of plasma and stool-based factors in treatment outcomes. Next slide. So we launched the study with the objectives of improving our understanding of risk factors and biology of young onset colorectal cancer, and then leveraging that new data to discover novel means for prevention, early detection, and treatment. Next slide. So again, this is a prospective longitudinal cohort study. Any patient diagnosed with colorectal cancer under the age of 50 who's seen in one of our participating centers is eligible and approached at their first visit. And if you click again, our goal is to have comprehensive collection of data and biospecimens, including tumor tissue, germline and somatic DNA, serial blood samples, medical record and treatment information, serial stool samples, as well as validated diet and lifestyle data. And along the way, we're also enrolling healthy control patients under the age of 50 to hopefully do some nested case control analyses as well. Next slide. And if you just click a bunch of times here, there's some animation. In order to understand, for example, the role of the microbiome in young onset disease and treatment outcomes, we do want to try and collect serial data as patients progress through treatment. And if you click a couple more times, we also do want to do in specific patients some fresh tumor biopsies, as well as serial collection of diet and lifestyle information for correlates. Next slide. And so you can imagine with a database and research study like this, the kinds of questions that we are now starting to be able to address, including what are the differences in genetic variants and gene expression and protein expression between young and older patients? Is the tumor immune microenvironment different, as well as the gut microbiome? And can we develop non-invasive technologies that are better than colonoscopies and will have a better uptake for screening and early detection? And again, is the biology of this disease different in responding to treatment? Next slide. And so what we think is that, this is likely a complex interplay of diet, host immunity, and the microbiome, where each of these individual factors independently lead to the development of cancer, but are likely also shaping each other to also perhaps increase susceptibility to this disease at a young age. Next slide. And so with the launch of our center in 2019, we are seeing an increasing number of young onset patients each year, starting in 2019 with 224 new young patients, and then now last year up to 267, which certainly is gratifying to us because hopefully they're being provided with, better comprehensive care, but also partnering with us in this research effort. Next slide. But we do need to collaborate and work together because, 200 patients a year is still not very much and will take way too long for us to be able to answer some of these research questions. And so we have partnered with several institutions internationally and nationally, including UCSF, St. Luke's Cancer Institute in Boise, Idaho, VHIO in Barcelona, and a large cancer center network called Oncoclínicas in Brazil. Next slide. And then finally, because so many of our young patients are utilizing social media, we are now using digital social media platforms to directly partner with patients no matter where they are in North America, namely the United States and Canada. This will allow for much more rapid accrual as well as collection of biospecimens and data. What it also helps to address that Dana-Farber is not as well equipped to address is enhances diversity and inclusion in research and will hopefully allow us to reach racial, ethnic, socioeconomic, and geographic populations that have traditionally not been as easy for us here to reach. And importantly, being able to do this remotely enables research to continue during pandemic times. So if you click just one more time, this is the website our colorectal cancer project has launched. And so accrual is picking up and we hope to enroll as many colorectal cancer patients as possible in this effort. Next slide. And that's the end. I just want to acknowledge all my different collaborators and teams across various institutions that have really helped in this work and really highlight the role of patient advocates in this work as well. My funding sources are listed here as well. Thank you so much, and I'm happy to take questions.
Thank you so much. Questions for Dr. Eng?
Pete Zareski with Amgen Medical. I really liked the presentation, very thorough. You mentioned about that the screening age is being lowered and probably will continue to do so. And you also mentioned that we need more less invasive testing, such as colonoscopy for the younger patients. So do you think that the adaptation of a lower age to start screening will incorporate the stool stool DNA test more than colonoscopy?
It's a great question. Yes, so I do think that our approach is very much the best screening test is the one that gets done. And stool-based tests are a great option that is much more convenient to be done at home, especially with this young population who still has to work and has busy, personal and family lives. Doing a stool-based test may be more feasible and more likely to be completed than going in for a colonoscopy. In addition, because most of the colon cancers that happen in young people are left-sided, which are the ones that are most likely to present with occult blood and bleeding, those stool-based tests really may become a great and effective way at screening and early detection. The caveat there is that these stool-based tests are predominantly good at catching early cancers and not as good at catching things at the polyp stage. And so they have mainly impacts on decreasing cancer mortality by catching cancers at an earlier stage where they're more curable, but less of an impact on reducing incidence through prevention by removing polyps. Although every abnormal stool test requires a follow-up colonoscopy, in which case any polyps found then certainly will be removed. But again, we do need something more non-invasive, like a blood test, like a microbiome-based test. And I think many different people are working towards that goal.
One other comment, which relates to everything you've said, it aligns with everything you said. I've seen a lot more commercials on TV of late, making the stool DNA test more recognized. And so now I understand why. Thank you.
Yes.
I have just Jeff Bernberg from Hawaii. I have a simple question. What is the time for, let's say, any type of lower GI symptoms, particularly bleeding, in these individuals as compared to the older individuals? I mean, my own anecdotal experience, being a physician in the military, we have a lot of young individuals, and many of them would have rectal bleeding for a prolonged period of time attributed to hemorrhoid without any exam. So I'm wondering if that's your experience. Thank you.
It definitely is. Many of these patients get diagnosed with hemorrhoids first. They get diagnosed with irritable bowel syndrome. And all of this leads to often 6 to 12 months delay in arriving at the correct diagnosis. The problem is challenging, and I really don't envy these primary care physicians who have to decide when it is to refer a young patient with these symptoms for further workup. Because, if you look at the numbers, it is still much more common that rectal bleeding is due to hemorrhoids, and IBS is probably much more common than colorectal cancer still in a young person. So, our advice and guidance has been that if symptoms persist, for 1 or 2 months and are not going away, that's probably the time to refer a young person for further workup.
Is there data that can be extrapolated perhaps from other populations about whether a 6 to 12 month delay in diagnosis is actually the cause of the really high rate of advanced disease that you're seeing? Or is the advanced disease perhaps a biologic difference or something else?
Yeah, I think there are studies going on to try to study that. I suspect it's going to be a combination of the two. I do think the fact that this population is not being screened is a big reason why we are seeing so many stage 4 diagnoses.
I had another question too. Is there a viral correlate that's ever been found? I know that HPV infections have been shown to cause some non-Hodgkin's lymphomas in the head and neck in young adults, and I thought I had seen that about rectal cancer as well in young adults. Has that been borne out?
Yeah, so not really. HPV is associated with anal cancer, which is a squamous cell carcinoma, and different from rectal adenocarcinoma, which is the type that's predominantly rising in young people. So right now, no direct associations with viral etiologic factors, but there are many viruses in the microbiome in the gut as well. And so we will be looking at all the different organisms in the intestinal microbiome to try to see if there are any significant associations.
Other questions? I have another one if not. So I'm super interested in this very robust clinical program that you've developed. And I know a lot of people in this room and probably also who have logged in have their own disease specific program that they're trying to target for younger people. And so can you say a few words about how you got started? I mean, clearly you're nicely funded. Is it from philanthropic funds within the Dana-Farber? And what were the first things that you did to try to target special services for this population?
Great question. So it was largely philanthropic funding committed to this by my division and the Institute, who really believed in the importance of this program that helped to launch this. And as we started going and getting more patients enrolled and generating some preliminary data, this funding from grants and foundations then came through. I am fortunate in that, there were other young onset programs for me to learn from already by the time that I started the center, including the Young and Strong program for young women with breast cancer that Ann Partridge started. We also have a very robust survivorship program that already had the resources of, nutrition and exercise and fertility counseling all in place already that we could tap into. So the very first thing that I did was to talk to all these services to make them aware of what we were doing and the needs of my specific population, get them all on board, and then to hire the social worker and the patient navigator, who we decided would meet in person, face to face, with every young onset colorectal cancer patient that came in at their very first visit, to make sure they were aware of all these resources and that nothing was missed in that initial medical evaluation. Because so often, as many of you know, the medical oncologist is focused on starting the chemotherapy, getting the port in, and we don't often or sometimes forget about the fertility and the sexual health counseling and the nutrition. So to have all these things comprehensively addressed and reliably addressed, that was one of the main goals of our clinical program.
Excellent. And is your practice tailored mostly towards young adults, or do you spread the young adults across the whole team that cares for colorectal cancer?
Yeah, so the Young Onset Colorectal Cancer Center is a virtual center where all of my colleagues in the gastrointestinal oncology division are able to see young patients. I actually see patients with all types of GI cancers, not just colorectal, but more and more my referral base is young patients with this cancer.
Wonderful. Thank you.
Thank you.
All right. Well, thank you so much, Dr. Eng and Allison Rosen. Next is going to talk about shared decision-making in colorectal cancer. Yeah.
Okay. Awesome. I feel like it's a really good segue now as a early age onset colorectal cancer patient to talk about some of the things that were just brought up. So I was 32 when I was diagnosed. So a little bit about me. These are my disclosures. A little bit about me. I was 32 when I was diagnosed with colorectal cancer, and I happened to be working in a cancer research lab at the time. So I knew a lot about oncology, I knew a lot about cancer, but I never knew that I was at risk. And so the picture of me looking very sickly was after my first surgery that I had, and my dad took it, and I never thought I'd ever see this. I never thought I'd ever use it, but I really use it in educating and advocating in the community about the importance of screening, especially younger people, about the importance of screening or the importance of knowing the signs and symptoms for colorectal cancer so that they can be their own best advocate and talk to their doctor. Because you heard those numbers. Sometimes people are delayed. Sometimes people don't listen within the medical field. Sometimes you have to go to 3 or 4 different doctors for them to really listen and take some of the symptoms that you're having seriously. It might be hemorrhoids, but it might be colorectal cancer as well. So I was working in research. I got diagnosed when I was working. I tried to work as much as I possibly could. Luckily, I live in Houston, Texas, so I have one of the best cancer centers across the street from where my lab was. So they allowed me to do some work, walk over, get my radiation, get my chemotherapy, walk back. And I walked and I did all that until probably the last 2 weeks of radiation when I wasn't able to. And I'm born and raised in Houston, so my parents lived there, so they were my caregivers. So my mom would pick me up from work, drive me to radiation, drive me home, and so on and so forth. So I also was lucky that I worked in research, so my boss was very flexible and was really amazing with telling me, just do what you can as far as work, take care of yourself, go to treatment, and come back when you're ready. So that was amazing. I had a supportive system, and not a lot of young adults have that. I've talked to many, and I'm really active in the community, so we'll talk about some of that in a little bit. So I went from cancer researcher to cancer survivor to switching careers totally. After I went through my treatment, I realized that my brain didn't quite work how it used to work. The chemotherapy affected my memory. And so a simple PCR that I used to be able to do from heart, I wasn't able to do anymore. And I sort of got involved in advocacy, and I realized that my true mission, my true passion was going out in the community, sharing my story, educating about the importance of screening, telling anyone that would listen about what I went through, and sort of talking to people one-on-one, because sometimes people aren't as open about colorectal cancer and certain symptoms as they are with other cancers. So I wanted to break the stigma. I don't look like a colorectal cancer patient, but no one looks like a colorectal cancer patient or a cancer patient in general. But when people saw me, they're like, "You're so young, I don't understand this." And even in the waiting room at MD Anderson, a lot of times my mom, they would think my mom was a patient. So I talked to people whenever I saw a young adult there. I would go and talk to them, and they didn't know they wanted to be my best friend, but I made them my best friend. So I moved into a different field at the same area and at the same institution, doing cancer outreach, education, and health disparities. And so that I've done sort of all that sort of stuff in research, a lot of different cancers, sometimes focusing on colorectal, so focusing on cervical, HPV, so any cancer that's screenable. I've worked in that field, and I've been lucky that I have the experience in research and I have the experience as a survivor. So my goal is to help bridge that gap between the two, because I want researchers to not work in silos. I want patients to feel like they can work with researchers on clinical trials, on anything as far as research, because I feel like the patient voice is so important. So a little bit about my cancer journey. I could talk for an hour about what I went through because it was really comprehensive, but a little bit of my history and my cancer journey. I'm now a 9-year colorectal cancer survivor. I have a history of Crohn's and asthma. So I did have a higher, I guess, likelihood of potentially getting colorectal cancer, but I had no idea about that. My mom also has Crohn's, has not had colorectal cancer. So I've had my genetic testing. So it's very interesting to me. The biological aspect of young onset colorectal cancer. I've had 4 abdominal surgeries, chemotherapy and radiation I had. I have a permanent ostomy after multiple surgeries. I'm a sepsis survivor 4 times of different things that happened along my journey. I have kidney disease, infections, and kidney stones. And a few things I left off of here as a young adult: I have osteoporosis, I'm postmenopausal, permanent chemo brain, definitely permanent chemo brain. I meet people and a year later, I won't necessarily remember them. So I feel like even though I had colorectal cancer, I got really active within the AYA community because that was the first community I was exposed to at MD Anderson. I went to an event with a bunch of other young adults, and I was like, wow, I'm not alone. I have other people just like me that get it. And that event, we went to the zoo. That event, we paid no attention to the animals. We just all talked to each other. And these people, after a few hours, felt like family to me. And so I got involved there. And that's how I think, shifted my whole career and realized that talking to other people, educating other people, and working with other people within the advocacy community and the healthcare community can make a huge difference. So this was sort of talked about because I know that Dana-Farber's clinic talks about all of these things, but I want to sort of go into all of these a little bit more in depth as an AYA. So the first thing I asked my doctor when I had my first appointment was, can I see a psychologist? Also, can I talk to another young adult like myself? And they did. They allowed me to see they found me a psychologist because they had one there. They found me a patient to talk to. They have a program called My Cancer Connection that you can get connected with other young adults just like you. And this perfect stranger really talked me down off a ledge when I was first diagnosed because I had no idea what I was in store for. And I think I talked to at least 4 different people throughout the first year of my journey. Support programs. Resources are probably the most underutilized thing I feel like within the AYA community. They exist, they're amazing. And I feel like social workers need to be at that first appointment. Navigators need to be at that first appointment so they can point those young adults into the right direction. Because my support group that we have for young adults at MD Anderson that I helped develop 5 years ago, I still go now. It still helps me now as a young adult because helping other recently diagnosed or even people that are going through survivorship issues like myself really helps me as a young adult still heal today. So support programs and resources are, I feel like, one of the most important things besides survivorship on this list right here. Then financial toxicity. I mean, that's just a given with the AYA community. It's not talked about enough. That needs to be talked about again at the very beginning. Another AYA colorectal cancer survivor came to me once and said, do you have any resources for me for my prescriptions. And I was like, yeah, let me go look. And I have a list of a bunch of resources that I've accumulated over the years. But she said, I can't afford my prescriptions because I need to put food on the table for my children. And that just that hit me like a brick. It's so crazy that, we're fighting for our lives, but yet we don't have the money necessarily to do so. And there needs to be more programs, more support, and more talk about the financial toxicity. A lot of my friends are bankrupt. They had to go bankrupt because, they didn't have the money to do a lot of the treatments they wanted. Also, I feel like with that, disparities come into play because I want everyone to have the same care that I had. I had amazing care, but I worked with federally qualified health centers, and those people that were going through colorectal cancer, some didn't get the same care that I got. I feel like they should have access to the same drugs, the same clinical trials, the same everything. And that's something that I'm passionate about. And I work still now with people on to try to figure out how to make sure everyone has access to the same treatment. Genetic testing. I had 54 panel of genetic tests, all the genes tested for me for colorectal and breast cancer. I don't have Lynch syndrome, which is really common in colorectal cancer. I don't have BRCA. My mom is a breast cancer survivor. My dad's mom is a breast cancer survivor. So sadly, as a young adult, I almost feel like it's inevitable that I might get breast cancer, but I am getting mammograms and I am getting screened. So I feel like young adults need to know about know about their genes, but know about some of the other preventative stuff that's available for them as patients and survivors. And then survivorship. Like you saw all the things that are wrong with me. I showed a picture in another talk that I gave that showed 20, maybe 30 different pill bottles. I have a medicine for every single one of those things that's wrong with me. I choose not to take some of them. And I've talked to my doctors about this. I haven't ignored them, but I have them just in case. So neuropathy, I have stuff for nausea, I have stuff for osteoporosis, I have stuff for so many different things that are complications that resulted from my treatment. But survivorship is going to be something that's so important to me. I go back yearly for scans, and I know that MD Anderson is developing an early age onset clinic, which is great. So all these topics are going to be discussed, and I'm on their board to help figure out how best to deal with how to reach all these patients, because a cancer hospital can be huge, and you have to make sure that everyone that's young has access to all these supportive services. And then oncofertility on here. That is something that when I was at MD Anderson, they didn't have a fertility specialist. So I knew to ask, but hardly any AYAs know to ask, especially the younger ones. They're not thinking about children. They're not thinking about families. And so, I knew to ask, but this needs to be a conversation that's brought up again, that first appointment. Do you want to freeze your eggs? Do you want to do this? When I was going through treatment, freezing eggs was really the only thing that I had as far as my option. Now, Dr. Woodard, who's at MD Anderson, is amazing. And she does lectures about all these different things. You can freeze your tissue, you can move your ovaries. It's amazing how oncofertility has progressed over time. And it's great. The first appointment, I feel like, should be with your surgeon, your oncologist. Then you also should have that social worker, that patient navigator, that patient advocate. You should have a separate appointment just to talk about every single one of these issues, because they all are relevant, and not just with colorectal cancer. All cancers where you're 18 to 39, you're considered an AYA. So next, the point of my talk, shared decision-making. And I'm going to go through these 5 steps and sort of talk about my experience, but also I posted on Facebook. I'm really active on social media. I posted on Facebook, and I asked other survivors that are in my network about shared decision-making and experiences they've had. So I'm going to share some of their experiences as well. So I brought my computer up here because I wanted to read the actual definition of shared decision-making for those that haven't read the official definition. It is key component of patient-centered healthcare. It's a process in which clinicians and patients work together to make decisions and select tests, treatment, and care plans based on clinical evidence that balances risks and expected outcomes with patient preferences and values. So There's a lot of big words in there, but essentially each one of these steps goes through this whole decision-making process with the patient and the healthcare provider or healthcare team. So the first step, seek your patient's participation. Communicate that a choice exists and encourage your patient to become involved in the conversation. Now, I was talking earlier to somebody and, I think my mom, if she were to go in, well, she went in for treatment. She basically, the doctors knows best. I'm not going to ask anything. I'm just going to trust that they know exactly what they're doing. And it's not that I don't think they do. I think they do, but I feel like younger patients, especially AYAs, have a voice, have opinions, really need to be, everyone needs to be a part of the shared decision-making process. But young adults, I feel like, will speak up more if they know sort of that they have a choice. And so I feel like communicating and starting that on the first appointment is the beginning of a beautiful relationship with the patient and their caregiver or care team. 2, help your patient explore and compare treatment options. And part of the definition, discuss the risks and benefits of each option. I think this wasn't done as much as I would have liked during my treatment. And a lot of people don't necessarily understand the risks and benefits. They're just like, get the tumor out of me. I don't want it anymore. I don't want to think about long-term, survivorship. And I should have thought a little bit more about long-term survivorship. I said I had 4 abdominal surgeries. I probably could have had 2 if I had really knew where to go, but also had an open and honest conversation with my surgeon and my team about surgical options that were available to me. Assess your patient's values and preferences. Take into account what matters most to the patient. So going back to the 4 surgeries, I told my doctor that I didn't want anything external as far as surgery was concerned, because I had gone to Google and looked up and saw what an ostomy was, and all this horrible stuff came up, all these pictures that made me like, oh, I was crying. It was just like, I don't want this. I want something internal. I want people not to know that I had cancer. I want really to move on with my life. That's what I thought. And look at me now. All I do is I work in cancer and I talk about it very, very, very often as an advocate. So talking to that patient, and so one of my friends lives in rural Texas, and transportation is a huge issue for her. And really driving and leaving her family, her kids, is a huge thing for her. So when it comes to treatment, she has to find a caregiver to drive her to MD Anderson or to wherever she's going. I think she went to Texas Oncology at one point. She switched different hospitals because she's in different trials right now. But what matters most? Does having a family one day matter most? Oncofertility. Does, the surgical option talk about body image? Does, it's just, there's so many different things and so many conversations to have with the patient. So really asking what matters most to you, and then having the clinician, nurse, social worker, whoever is tasked with that, what is most important to them as far as their cancer journey and side effects. Reach a decision with your patient. Decide together on the best option. And I really think my surgeon maybe was afraid of me, because I was like, this is what I want. I don't want any other option. I don't want an ostomy. No. So when I asked to be matched with a patient, what he probably should have done at that point was match me with an ostomy. So someone else that had an ostomy that could tell me that it's not that bad, it's not horrible, because that's what I do now. They have an ostomy support team there now, and people that are thinking about or might have an ostomy, I go and talk to. Before COVID, I would go in their hospital room and I'd walk in with a tight dress and they'd be like, who are you? I'd be like, I'm a volunteer and I'm also a colorectal cancer survivor. I also have an ostomy. And they just would gasp, because they're like, you're wearing normal clothes. You don't look sick. All these different things they would say to me. And I was like, well, this is why I'm here. I'm here to tell you about my experience. I'm not here to sway your decision on if you want an ostomy or not. I'm here to tell you about my experience, because really my ostomy gave me my life back. That J pouch, I was in the hospital with infections, after infection. I lost a ton of weight. I was 80 pounds at one point. I couldn't go on road trips. I couldn't do anything. I basically stayed at home all the time because I was worried about if I ate or drank anything, where the restroom was. I knew every public restroom, on the way to I worked a mile from work, but I knew every public restroom. And I think the mental aspect of it for me was just as much as the physical. So I knew, oh, I don't have a restroom near me. And I'd stop at McDonald's almost every morning. They knew me by name. I always bought something because I felt bad. I didn't eat it because I didn't want to, but I knew that their restroom was about halfway through where my condo was and where the hospital was. So deciding together the best option, having an open and honest conversation, again, is so important. Lastly, evaluate your patient's decision. Is the decision reasonable? And this goes back to any concerns. What I didn't mention earlier is that also what helped me is I was obviously a cancer researcher, so I could read some articles, but giving some of these articles or valuable resources, verified resources, great websites to go to, not Google, giving those to your patient, having them come back and then discuss those with you so they could ask all the questions that they're going to have. Because believe me, neoadjuvant, all those sort of words, an average patient, especially in AYA, is never going to have seen, never going to understand. And so I think after they've talked about the decision, let's evaluate together. Let's make a pros and a cons list, and then you can make that decision. But really, they need all the resources that they have that are accessible and that they could use to make that decision. So talking to other young adults like them, research, good, valuable websites, verified websites, and really, I think talking about survivorship and thinking about what we talked about earlier, what matters most to them, and involving their caregiver in that conversation is really important too. I mean, my mom took care of me for 9 months after I had my surgery, but younger adults, it might be a husband, it might be a wife, it might be a sister, it might be a brother. They have to be involved and know that if she's going to get this surgery, she might need somebody to care for 8 weeks. Are you available to do that? My mom was able to drop everything and be there for me, but a lot of young adults that don't have maybe parents that can help them, that maybe have a husband that has to work so he can pay for the treatment that the wife or whatnot is going through, needs to be involved in that decision as well. So these are this is a summary slide of everything that I just talked about. Participate when patients engage in shared decision making, and this is from a website, and I adapted it to represent the AY voice as I know it. Participate in education about their health. They better understand their condition. Some people have no idea after they're done with their diagnosis or their treatment what really they went through. They can't even name the chemotherapy drug that they've been on. Recognize that a decision needs to be made and that they have options. Everyone has options. Now, in the world that we live in with research, there are so many options that are available. I want to say with clinical trials, there are too many options sometimes, especially for young adults. And colorectal, I can't even tell you how many options there are for clinical trials. And so many times people ask me, do you understand this? Do you have more information about this? And I'm like, I'm not a medical provider. I can't give you that information, but I can point you in the direction to the person, the research coordinator, and they can explain it a little bit more for you. Because when you're deciding on a clinical trial as a young adult, a lot of times you have to move, you have to travel, you have to think about so many different things. There's a friend of mine who, parking is expensive. So because of that, and because of travel, she raised money to get an RV. So she has young kids and she raised money to get an RV, and she takes her RV to her treatment with her kids and her husband every time she needs her treatment, because housing and parking and everything related to that, they have a little kitchen inside the RV too, food, was making them go bankrupt. So this was her solution. And she talks about her story openly, and she's involved in a clinical trial right now. And she can do that because she raised money to get that RV so she could travel. So understand the pros and cons. Like I said, make that pros and cons list and really talk through each one of those reasons why it might be good or why it might not. Have appropriate information and tools, need to evaluate their options. Appropriate decisions and tools, no Google, unless that you tell them where on Google to go. So the research articles, the resources, the nonprofits, the other patients. They're prepared to talk with their healthcare provider, not just this oncologist and surgeon. I probably saw every single department at MD Anderson when I was there. I saw dermatology, I saw endocrinology, I saw urology, I mean, I now get my mammograms there. Like I literally go to every single department. So starting with the first home clinic and having that shared decision-making conversation will empower a patient to have those same conversations with their doctors that are in the other departments and their long-term survivorship care. It might not be at the same clinic that they went to originally. So you're giving them and you're empowering them to have those conversations with all their providers. And then collaborate with their healthcare team to make a personalized decision. Personalized medicine, patient experience, patient-centered care is they're buzzwords, and they're all important. And I love that the word patient is in a lot of these. And they're more likely to follow through on their decision. And AYAs are some like, I don't know, am I going to do this? I don't know. Shared decision-making will help increase that likelihood that they're going to follow through on their decision. Benefits, there's benefits for us as well as the healthcare provider. Some of these are sort of repeats. What I will say that for the healthcare providers, shared decision-making shows increased provider and patient satisfaction. So when we get those surveys, it's yes, this is great. Yes, this is great. My oncologist, I love him so much. We have a great relationship that I know him so much because we've made so many decisions together, even not related to my colorectal cancer, but I was having some of those kidney issues that I mentioned. But he was the one that put me in the hospital when I was in the ER. He's the one that came and saw me. And I got to know him very, very well with all the surgeries and all the different complications that I had, that I know him so well that I have chocolate waiting for him every time I'm in the hospital, because I know he'll spend maybe an extra 5, 10, 15 minutes with me. And he's comfortable enough that he walks in, grabs the bag because he knows I know, and pulls that chocolate bar and starts eating it. So I love it because he's someone, we have mutual respect for each other, and that leads just to better satisfaction. Benefits for patients, there's the patient experience right there. My patient experience at a hospital that's huge is more than just my armband. It's not just a number that's on my wrist. And the reason why I chose that specific oncologist is because I went in, I had 3 different opinions. I went in and he said, you're more than just a number. I know you're young. I know your cancer is different than all my other older colorectal cancer patients. And I want to make sure you know that your care is going to be specific for you and personalized. And if you have any questions, here's my cell number. I've never used that cell number, but just knowing that this oncologist that had a great reputation gave me a cell number was just like the relief that I needed to know that I'm in good hands. I also have been out of town and been sick, and someone did use my phone to call him, and he met me in the ER after getting on a plane and made sure that I was taken care of and admitted so that I would be okay. And that's above and beyond what I had seen previously in care before cancer. So there's also suggested language. I talk about in my everyday job, I talk a lot about colorectal cancer and what to say to specific populations in order to get them screened. So I thought this was an appropriate slide to include because these are some things that have been proven through surveys with all AYAs as far as things to say when you're talking about care and shared decision-making. Sometimes things in medicine aren't as clear as most people think. Let's work together so we can come up with a decision that's right for you. People have different goals and concerns. As you think about your option, what's important to you? Do you want to think about the decision with anybody else? Someone who might be affected by the decision, someone who might help sort things out. And then this is an extra slide I had to put in here because health IT tools are being used more and more often for shared decision-making. And so interactive decision aids, patient portals, personal health records, secure messaging. I send messages during my treatment and everything. I sent messages so often to my care team and they got back to me. So EHR is a really good tool to use for shared decision-making so that that patient isn't calling all the time. If they know someone's going to answer that message, then they're not going to call and bog that line down with, hey, there's something weird on me. I need to talk to somebody. So using EHR for giving them decision aids and for communicating back and forth is a really, really powerful tool. And this is, I do a lot of talks on empathy. So I wanted to add one slide about empathy and give you one more story about someone from my care team. So the most powerful skill a clinician can have is genuine empathy. If their eyes are tearing up, you hand them a tissue. It can go a long way. It makes the patient feel as if you're really trying to understand them and that you care. So Shared decision-making is about showing that you care. Having empathy for the patient is showing that you care. And I was in the hospital at one point, and someone was typing on their little computer, because a lot of times everything is on the computer. It's not written anymore. So there's not a lot of face-to-face interaction. I was bawling my eyes out because I was missing my best friend's wedding, and I was so upset. And I was like, put a tube in me, do whatever you have to do. I want to get on that plane. I want to go to my best friend's wedding. And they're like, Allison, you can't do this. You're really, really sick. I was in denial, as many AOAs often are, that they're actually sick with certain things. And so I was bawling my eyes out. It was a mess. There's no tissue except for that hard stuff that they have in the room that's really hard on your nose. She left the room. She said, I'll be right back. She left the room, got me some Puffs Plus that they had behind the station, the nurse's station, and brought it in to me. And that made a huge difference for me, because I was like, she calmed me down. I had Kleenex. And then we had, a conversation about like other things I could do with my best friend once she got back from her wedding and I was out of the hospital. So empathy is huge and makes a huge, huge difference in any patient's life. And that's it. I'm on social media. As I said earlier, most AOAs are on social media. And I empower, I don't know if, I'm sure AOAs are not necessarily listening to this, any other patients. There's, Lauren, who's the community advocate, is like me, but Twitter is one of my favorite tools in order to reach out to clinicians and talk with them. And I've had many reach out to me because I'm active on it to participate in some of their trials or help with some of their research grants. So find your patients and see what's going on. If you're on social media, don't friend them. You don't have to friend them. I'm not saying that, but we share a lot on social media, probably more than we should. So it could open the window into sort of what is really going on in their life. And that is it. Thank you. Do you have any questions? And Lauren, do you want to come up? Because you can probably answer some as well. Okay.
Allison, that was great. You said a couple things that made me think, and I can open up this question to anybody.
Yeah.
Dr. Eng, you mentioned your surgeon was afraid of you. You mentioned that you had to go to several physicians to take care of each individual system problem or issue. It seems to me, if this model could work, to have an MD who is a survivorship specialist, who could be sort of the quarterback for you or any cancer survivor, and they would be trained in disciplines involving oncology, social psychology, et cetera. So they would be able to understand all of your issues and be able to work with other healthcare providers to get your needs addressed in an expedited way. So like I said, I was in almost every clinic at Anderson when I was there, and my oncologist was my main person that I saw, but they all work together behind the scenes. I was told this, and at one point I went out, I saw a huddle of a few of them, and they were on the phone with each other. They do have survivorship clinics. I will eventually go to a survivorship clinic. With me, since I had surgery 3 years ago, they want to wait till 5 years after so I can go to that survivorship clinic. And I think that person is trained on all the different things that I'd have to deal with. And there's survivorship clinics for breast cancer, for colorectal cancer, for all sorts of different things. And they are creating, I know, like a lot of people are creating programs specific for young adult AOA patients for colorectal cancer and other. I feel like every cancer that sees AOA patients should have a clinic specific, because our needs are different than everybody else. So as the trend is picking up and hospitals are supporting this, more AOA specific survivorship clinics or cancer specific clinics for AOAs are happening. And I'm going to take full advantage of the early age onset clinic once it opens at MD Anderson, because of all these things that I have going on, because, I'm not taking medicine for the osteoporosis right now because of my age, but you said that I probably should, but I have to remember to go see her again. And I might not remember to go see her again for like 5 years.
And at that point, it might be because something hurts, but I think there is survivorship clinics that exist at a lot of these places. I just haven't moved there yet because I'm not quite at 5 years since my last surgery.
Michael Fish from Houston, also from Houston. Allison, thank you for that wonderful talk. So at the Symptom Control Quality of Life Committee earlier today, we had a symposium where we were talking about toxicity.
Yep.
And there was the distinction made between safety of treatments and tolerability, and a lot of emphasis on the patient experience over time. One of the things that we didn't get into today, but was on my mind as I heard your remarks, was this notion of time toxicity. And this was something that was written about in the Journal of Clinical Oncology by Dr. Arjun Gupta and colleagues just this past month. And it has to do with, just the impact of the amount of time that it takes to get care.
Mhm.
And I was thinking about you having multiple different health issues, the idea of seeing a fertility specialist, the idea of seeing somebody about bone health, as well as your cancer doctors, but also just the unique impact that AYA, young adult patients may have with time. Many of them don't have the same kind of job that you had when you got diagnosed. So they work by the hour, or they're in the gig economy. And if they keep doing what we're asking them to do, they can't make a living, or they can't pick up their kids from school. And time toxicity is very hard to wrap our heads around as oncologists, because not all patients experience it the same way.
Yep.
And the time is not linked to their income in the same way. And so I was thinking, gosh, we want to explore the unique biology that may or may not exist with this disease, but the unique patient experience and life experience and what it takes to fully understand what people are going through.
Yeah.
But I wonder if you would comment on time and its toxicity.
It's huge. So I had, I was lucky enough that I had a huge support system. I had people that would drive me here, drive me there, would sit with me when I was having my chemo, would do all this, but a lot of people don't have that. So I think that's where you take advantage of those resources that are available. And I've tried my best to help create like a comprehensive AYA resource list, because literally there are a lot of different things that would help deal with that time. Talking about FMLA to somebody who doesn't know that they even have that option as a young adult. They probably are just like, I have to take time off work, I might get fired. So I think there's so many issues, but trying to connect AYAs with resources that could help them no matter where they are. Like I said, I had a job that let me do whatever. So many people have had to quit their job. So many people had to leave their job, take a leave of absence from their job. Then they go to their treatment, they can't even do their job after. So I think that needs to be looked at so that we can get better resources to these people that need them, so that they can still get their care and not have to worry about financial toxicity. We were just talking about that earlier. But I spent so much time in every single one of my doctors. I would be there sometimes for a whole day, waiting to see a lot of these people. And this is where I think the survivorship clinic that I was talking about earlier would be really helpful. Someone that knew about all these different things, so that you reduce the amount of time that you have to spend in that hospital. So that's one thing. That's one thing.
Thank you. Thank you. And I was going to just say very, very briefly that it seems like young adults sometimes don't seem to want to tell anybody that they even have the cancer. So asking their boss for an accommodation or asking their friends to drive them, you've got to be willing to disclose. Yeah. And so then in a sense, that non-disclosure makes time toxicity even trickier to manage. All these little ways that you could manage it. Involve you having to ask for help. This
is why connecting with other AYAs is important. So I know somebody who will not disclose. Her family knows, her like parents know, but she won't tell her coworkers at work. She won't tell her friends, but she has the other AYAs that she's connected with that will help her. So I think that's really such an important part of the journey, because if they don't want to tell their like immediate support system or their work or whatnot, she's told people she's gone on vacation when she has to be gone for surgery. But we will be there for her. And I think that's why the AYA community is special, because we will connect, we will become fast friends, and we will be there for each other and for perfect strangers in a heartbeat if they need us.
Hi, Barbara Segarra, patient advocate first. Congratulations, we're so proud of you. While they were talking, Dr. Ayn was talking, I was thinking I have two boys, young adults, 28 and 32. So I'm thinking, what should I be talking to them about, what to look for? And my second, going back to what Dr. Fisher said and everything you presented, how can we get different oncologists to have the information or to know where to refer these young adults once they're diagnosed, so we can start, I can start in Puerto Rico with the people, oncologists that I know for that matter.
Well, so a lot of the social workers have these resource lists. A lot of nonprofits have these resource lists. Stupid Cancer is a adolescent young adult nonprofit that sometimes there's a conference called CancerCon that I've gone to, that a lot of the nonprofits for all the specific cancers have tables. And that's how I learned about a lot of this stuff to start out with. There's another amazing group called Elephants in Tea that on their website talks about all the support groups that you can go to as a young adult, all the different events that are happening. And COVID actually gave access to people all over the world to these programs that wouldn't have had them otherwise. So I know Dr. Eng was talking about their support group being open to other people, not just from Dana-Farber. So it's great that these larger NCI designated cancer centers are opening up their programs to people from all over. Our support group from our AYA support group at MD Anderson, in person, we'd have 10, 15 people. Since COVID, we went virtual. We might not leave virtual because we have anywhere from 40 to 50 people that come on that now. And they're from all over, because you don't have to be an MD Anderson patient. So I think knowing what resources at these large institutes that are available to anyone, no matter where they live, no matter where they're treated, are so important to get the word out. But also, we need to get like a list of all these nonprofits resource lists and put them in one library so people can search that. The problem with that I've heard is that, they change their website, they change people who manage things, things change over time. So you have to have someone managing that. So, I mean, in an ideal world, there'd be a click, you go and you look up colorectal cancer and here's all the resources, AYA, colorectal cancer. Also, all the resources for traveling, like Hope Lodge at American Cancer Study, where are all the Hope Lodges that I can stay for free. There's a place called Dan's House of Hope in Houston that you can stay for free as an AYA. So like, I have it in my brain. It needs to be somewhere online. And Lauren might know where else there are some great resources, because I don't know anywhere where it's all together as one. And then on to your son. So what I tell people when I do interviews or when I'm talking to anybody, if you have severe fatigue, blood in your stool, 100%, but severe fatigue, change in bowel habits, unexpected weight loss, all of the anemia, all that stuff. So for me, I was doing Zumba. I was in the best shape of my life. There was really, and I thought I was tired because I was doing Zumba. I was losing weight because I thought I was doing Zumba. I felt great. Really, for me, it was triggering that I felt like I had heartburn. So I had heartburn. I felt like food was getting stuck inside me. So like something unusual like that doesn't make sense and isn't normal for you, talking to your PCP about that and asking, okay, what might this be? They should know. So first I had an x-ray, and the x-ray, they're like, oh, we think you have a blockage. So I drank, something for a prep, and it didn't really help. And then I had a colonoscopy, and they realized from that colonoscopy, I had a 13-centimeter tumor blocking anything from moving down my colon. So young people need to be aware of all different cancers, all different screening that's available. And if something doesn't seem right, no matter what it is, they need to not be afraid to go talk to their doctor. And that's what I say on a regular basis. I thought, and I delayed. I wanted to go to my cousin's bachelorette party. I went, and I couldn't eat because I was in so much pain. And that's when I went home and I called my doctor. I'm like, the colonoscopy I have for 3 months from now, I think I need it now. And I was told by my oncologist, if I had even waited 1 more month, I wouldn't be alive right now because my cancer was so aggressive, because it usually develops in 10 years. And I had a colonoscopy that was perfect, clean, beautiful, 1.5 years earlier. So.
Thank you, Allison. That was amazing. I wanted to briefly just introduce, if you want to stand up quickly, Lauren Wagner is our new AYA community advocate. And we'll be excited to hear more from you at the next meeting, and also to see how your role in SWOG evolves. These community advocates are a new thing, and my hope is that both of you going forward can work with each other and with the other disease-specific committees to bring out the voice of AYAs as you have today.
Yeah, I know.
Welcome, Lauren.
I know we're available and willing to help with any AYA studies that are going on.
Perfect. Dr. Salzman.
Okay.
Go, just take your time.
Okay. All right. Okay. Thank you, Dr. Johnson, for this invitation. I'm John Salzman. I'm a clinical health psychologist by training, and at the Wake Forest School of Medicine, I wear a few different hats. I'm co-leader of our Cancer Prevention Control Program and the Director of Clinical Research in Adolescent Young Adult Oncology, and also with ECOG Akron, I'm in the AYA Subcommittee Chair, though. This is my first in-person talk since before the pandemic. So I've got to say, one of the things that happens when you're giving talks on Zoom is people turn their videos off. And for a lot of very valid, good reasons, right? The other thing that happens when you're giving talks on Zoom is you can't read the audience. You can't tell if you're connecting with them. You can't tell if your jokes are funny or not. That's good and bad, right? My kids tell me my jokes are not funny. So this will be a good test. I'll realize, yes, my kids were right. So the work that I'll be talking about is funded by the Childhood Cancer Data Initiative. The CCDI is designed to collect, analyze, and share data about the burden of cancer in pediatric and adolescent young adult cancers. 2 years ago, the NCI had specific funding that they dedicated for in-core sites to help improve the capture of PRO data. So Allison did such a fantastic job about emphasizing why we really need to understand the patient perspective. One of the areas that I focus on is on measurement science. Why do I care about that? Because I think we need to center the patient experience. We need to amplify their voices. One of the ways we can do that is through reliable and valid PRO measures. The challenge in adolescent young adult oncology for 15 to 39-year-olds is there's limited reliability and validity data for these measures because they have to cross the pediatric and the young adult space. And patients a lot of times just don't fill out the measures. So there's a lot of missing data. So we being ECOG Akron, applied for and got supplemental funding to do this work. We have a fantastic multidisciplinary research team, as most good work in AYA oncology. We heard this from Dr. Ng, from her research team. AYAs have such a host of psychosocial issues that there's multiple providers. It really does take a village in AYA oncology. So we have a fantastic team. We have patient advocacy on the team as well. And we've been able to branch out and include AYA study champions from, well, I was going to say from each of the NCTNs, to be determined. We're getting there. As I mentioned just briefly by way of background, we need to collect more data on PROs. It's inconsistently and unreliably measured. We need, because PROs can be very time intensive, and sometimes if you're ever sitting in a doctor's office and you're going through the checklist, you're like, you already asked me that, or okay, this is taking too long. So we need something that really captures this data in a quick, efficient manner, and it's valid and reliable. We know from Allison's comments that AYAs are digital natives. There's a great slide about health IT. And so one of the things that we're hoping to do is leverage ePros to be a more efficient way of collecting the patient voice. So we know that, well, we think this can work with AYAs because greater than 96% of them have smartphones, greater than 96% of them have access to Wi-Fi. So when we talk about digital divide in research, that's essentially non-existent in the AYA patient group. So there's a good opportunity to leverage technology to do a better job about representing their voice. ECOG Akron has what they call Easy Pro. In kind of a colloquial way of describing it, it's their red cap or their survey monkey. What Easy Pro can do, it's a platform that can collect ePro static short forms. What it can't do is do computer adaptive tests. And I'll get into why that's important in a little bit. Right now, in fact. I have no note slides in front of me, so I'm winging this a little bit. But one of the beauties of computer adaptive tests is you can assess more domains without sacrificing precision of measurement. So fewer items, less burden on patients, but you still get a really strong informative score. Based upon how a participant responds to an individual item, each subsequent question will then narrow down and get a more specific focus on that particular domain. So with each subsequent question, statistically, you get a reduced standard error of measurement. So you get more reliability, more confidence that what you're measuring is something that's valid and reliable for those patients. Our project's goal was to increase the capacity for collection of electronic PROs for AYAs by allowing Easy Pro to collect computer adaptive tests. That was one of the broad kind of project aims. And then we had some study specific aims. The first aim is to evaluate feasibility and acceptability of completing PROs among AYAs randomized to choice PRO or fixed PROs. In a nutshell, what we're trying to do here is basically, can we do this? Is it feasible to recruit AYAs? We know that the vast majority of AYAs are treated in community-based practices. Where is the vast majority of AYA research done? It's in NCI designated cancer centers, comprehensive cancer centers. It's great data, it's interesting data, but we don't always know how representative it is. AYAs have access to a whole host of resources that we heard from Allison and that we heard from Dr. Ng. It's fantastic, but that's not where most AYAs are treated. So one of the things with feasibility is, can we do it? Acceptability. Do AYAs like this? Will they do it? This randomization piece, and I'll show you a schema here in a minute, is between Choice Pro and Fixed Pro. Allison did a nice job of talking about measuring what matters to the patient. One of the things that we think about when we collect PROs is, what's the most important to the patient? As providers and clinicians, we have a pretty good sense of that, but it's filtered through our lens of our experience seeing a number of different patients. And there's individual difference variables that factor the patient's experience. So with Choice Pro, we're giving AYAs the opportunity to pick their most important health-related quality of life domains. Our hunch is the arm that's randomized to the group that gets to pick those most important domains will have a higher response rate. Well, there'll be less missing data. In a way, we look at this as a precision pro trial. The exploratory objectives is also to take advantage of this opportunity that we have to collect data on AYAs. There's very few studies like this. And so we don't want it to be a missed opportunity to get data that can inform future studies. The first exploratory aim is to look at AYAs' health-related quality of life priorities in their PRO trajectories. This is a study that's done over a year with 5 different assessment points. At each assessment point, we ask AYAs from a landing page, a dashboard of 15 health-related quality of life domains, what are their most important ones? They get to rank that. So we're interested in what's important at diagnosis, what's important once they're midway through treatment, what's important when they're on post-treatment survivorship. I have some other data that suggest those things change. Allison mentioned the importance of financial toxicity. When we've talked with AYAs that are on treatment, that comes up some, but it doesn't come up as often as when they're off treatment. When they're off treatment and the bills start coming in and they're trying to get back to work and maybe they're having a hard time getting back to work, what happens on treatment that they're more focused on is pain, physical function. It's the side effects that are treatment related. The second exploratory aim is to look at access to and utilization of psychosocial and financial resources. AWAs are at disproportionately greater risk of psychological distress, clinically significant levels of psychological distress, as well as disproportionately greater risk of financial hardship compared to older adults with cancer. This is not a CCDR study, and Ruth Carlos is our CCDR champion on this trial, and she describes this as this is putting the veggies in the mac and cheese, because since it's not a CCDR study, we kind of have to embed those elements in there, but we want to inform future studies to look at uptake of psychosocial services, look at uptake of financial navigation, uptake of those resources in the in-course setting. And our last exploratory aim is to look at AYA's preferences for how their PRO data should be shared with them or their providers. This is, when I've talked with clinicians about this, this is the piece that they're most interested in, because they want to know, okay, we've got the PRO data, now what do we do with it? For us, this is about actionability. How can we make PROs actionable? What do you do with that data once you have it? So we ask AYAs, how do they want their PRO data shared? Do they want it shared with them? Do they want it shared with their families? Do they want it shared with their providers? I must have clicked something wrong.
Let's see, request that live transcription be enabled. I'll just inquire.
Oh, there he goes.
Okay.
Okay, I won't go through all the eligibility criteria. I'll just highlight one here. Since we're trying to capture AWAs across, I don't want to say across the cancer care continuum, because this was a 2-year study, and those of you that do work in the in-course setting know it takes about a year at least to get a study activated. So then you have a year to do that, the actual study part. We want to get AYAs at diagnosis and in the early stage of post-treatment survivorship. For some of the heme malignancies, we won't be able to get into the post-treatment survivorship, but for many of the solid tumors, we will. We want to get as close as possible to diagnosis, because that's when there's elevated rates of distress. That's when a patient is really trying to make sense of what's going on, and we would have a better sense of those things that matter at that diagnosis point, but we also want it to be feasible. So we've expanded the eligibility window. As I mentioned earlier, AWAs are digital natives. So there is no paper-based component to this. This is all digital, but we have a platform neutral. EasyPro is platform neutral, which means it can be used on tablets, PCs, smartphones, both Apple and Android. Those of you that are in the room, I'm probably preaching to the choir a little bit, so I won't go into this in great detail, but AWAs represent a lot of heterogeneity with respect to cancer type. Heme malignancies, CNS tumors can be more common on the younger end. Breast cancer, more solid tumors on the older end of the AYA lifespan. As a result, for our sample size of 400, we put in some ranges, because we don't want this to be a study where Vicki Champion did a study in breast cancer a few years back, and it was a really nice study, and it's really, I don't want to say it's easy, it's easier to have a study where you recruit for AYAs, and it's predominantly white women with breast cancer. And we know a lot about white women with breast cancer in the AYA world. That's one of the areas most commonly studied. We wanted to be able to look at some of the other cancer types too. So from SEER cancer registry data, we identified the 5 most common cancers, and then we have this group of other that represents a large sample size as well. We also didn't want, it's much easier in the social science world to recruit women to studies. Men often don't participate. That's why we had some disease, that's why we had a demographic cap for that as well. I mentioned the study schema. So participants are randomized to choice or a fixed pro. With the fixed pro, they get what research has shown us as the top 5 most common health-related quality of life concerns for AYAs. That's physical function, that's pain, that's cognitive function, that's social support, and that's finances. With the choice, they get to pick from a dashboard of 15 different options, and I'll show you those in a minute. By the way, if there's any sites that are interested in participating in this study, DCP did approve this for a base intervention funding amount of $1,000, because we know there's competing trials and there's some understandable concerns by sites about their ability to support these trials. We are interested in getting site level data. The landscape survey, the first landscape survey that was done in course settings that had CCDR components, there was a question on there that said, do you have AYA specific services at your site? Yes or no? That's great when they say yes, but we don't know what those AYA specific services are. So we're using the site survey here to try to unpack what services do they have to support AYAs? Do they have financial patient navigation? Do they have fertility navigation? What sorts of things beyond standard of care do they have at their sites? We also asked sites to complete this at 2 different time points. This is the clinical form that we asked them to complete at 2 different time points. We're looking at high-level information about the clinical characteristics of patients. Based on early conversations with sites, we do believe that this is a relatively low-burden trial. Here's why. The sites are involved at the screening consenting stage. That's being done by local CRAs. And let me back up. I've talked about this primarily in the NCORE setting. The funding is through NCORE, but it's approved at NCTN, NCORE, and LAPS sites. So there's multiple sites that are available to participate. The sites are involved with screening and consenting. They're involved with the site survey and the clinical forms, which we've pilot tested, and we did our best to make sure it was minimal burden or reduced burden for patients. I mentioned already that the pros are electronic based. What can Brown do for you? That's a nod to our Easy Pro group that's housed at Brown University. They're the ones that do all of the follow-ups. All of the follow-ups are done remotely. So the patient contact only has to be done at consenting and enrollment. Every single follow-up time point can be done remotely. Brown is responsible for doing those follow-ups. We do encourage sites to follow, CRAs at local sites to follow through with their standard of care for research studies and do nudging, but not feel like they have to go above and beyond there. This is an overly busy slide, but it just gives you an idea, a sampling of how we have approached this for the primary and secondary outcomes. For our feasibility rates, we looked at some of Ethan Bash's work at UNC when he's piloted other PRO studies. Said 75% was our feasibility threshold and our acceptability threshold. And for acceptability, we ask about whether it's easy or not to complete, easy or not to understand. And then we ask some secondary outcomes. Both arms will complete global health related quality of life, but then it diverges based on arm. What do we ask about? What domains are most important? The World Health Organization has identified a tripartite approach for decades now. They have a tripartite approach to health and well-being, which focuses on physical, mental, and social. Those are 3 main key core aspects of the human experience, but it fails to capture some of the unique nuances that AYAs experience. This systematic review was done by the group behind the EORTC AYA version in Europe, and they identified multiple different health-related quality of life domains. We use this as a jumping off point and then added our own domains. So we came up with 15 domains. An AYA will have once they're enrolled and participate in the study, the dashboard will be drag and drop. So again, we try to make it as easy as possible to rank their most important domains. For the computer adaptive test, it's one item at a time, again, because each subsequent item is based on the participants' responses. We describe this as a precision PRO trial. In terms of the overall study calendar, again, another busy slide, but the main point to focus on here is what's the burden like for the participant? I've been up here saying electronic PROs are low burden, they're more precise, you don't sacrifice any validity. Well, what's it look like for our AYAs? We've anticipated that we're targeting a 15-minute assessment, plus or minus 5 minutes there, depending upon how quickly an individual go through this. The range of items depends on the types of questions they get. Not all domains are computer adaptive tests. Here's what the measures look like. The patient-reported outcome measurement information system, it reflects the majority of domains here, because it's valid, it's reliable, it's been translated in multiple different languages. So many of these are CATs. Some of these that are short forms are a little bit longer, but that's because there's no validated CAT at this point. This is what it looks like so far. So how are we doing? We've been in the field since November, and we're a quarter of the way to our 400, our goal of 400. So we're really happy with that so far. These are the in-core sites. 290 sites have been activated already, or will have IRB approval. This is what it looks like by different groups, and with SWOG contributing 18 accruals so far, and these are the high accruers to SWOG. I will say, since many of these are in the Carolinas, Becky knows this because I talked about this recently, but the Carolinas, those of you that are college basketball fans know that the folks in Carolina view their state as the college basketball capital of, I was going to say the world, at least the US. And they developed a friendly competition among the groups for the site that had the highest accruing trial, while this highest number of accruals to this trial would end up receiving a basketball painted with the colors of those sites. So I don't know if any of those sites are on the call, but it was interesting to see how into it they were getting. So this is where we're at by sex and cancer type. The other of 28 reflects 10 colorectal cancers. So that's the most common cancer type reflected in that other category. Oh, and I didn't, it's not reflected here, but our historical accruals to ECOG-ACRIN trials for racial and ethnic minority participants hovers around 15%. We would like for this trial for it to be closer to 20 to 30%. Only 2 minority underserved in-core sites have activated the trial so far. We do have 19% of our accruals so far are racial or ethnic minority AYAs. So better than what we've done historically in ECOG-ACRIN. We would still like it to be upwards of 25 to 30%. And I'll quickly just cover these FAQs. We can't find the site survey. Where is it? Where, honestly, Becky, is this as relevant to this audience?
I think it might be.
Okay.
I mean, yeah, I think that some people might want to.
Okay. I'll go through this quickly because I know we're almost wrapping up. We can't find the site survey. Where is it? We're concerned about completing it in a timely fashion. There have been some delays in getting this activated. Our team is aware of it. We anticipate the site survey to go live within 2 weeks. We also have a form that can be shared with sites that are concerned about this so that the note can be put in and sites are not penalized for not completing that site survey in a timely fashion. What about DCIS? What about stage 0? Are those patients eligible? Because we know, and we had this conversation last night at dinner, we know that objective indicators of disease threat are not always a predictor of how a patient processes and experiences that level of threat. You can have a patient that has an early stage cancer that psychosocially, it's still very disruptive and still very alarming to them. So stage 0 patients are eligible for this. We've tried to remind our participants to complete the surveys. They tell us they're going to do it, but don't do it. What should we do? This goes back to that, how much should we follow up? How much should we nudge? We know that AYAs have some of the poorest participation rates in cancer clinical trials, both the therapeutic trials and the supportive care trials. Mike Roth and others have looked at those data and looked at barriers and facilitators of that. This is a pilot feasibility and acceptability study. We don't want sites to necessarily go above and beyond, because if what we're doing doesn't work, that's important information to know. We want sites to follow standard of care there, but understand the team at Brown has got this too. So the team at Brown can do this warm handoff. So follow through, nudge your patients, but understand it's probably going to be frustrating. You will have some patients that will say, sure, I'll do it, and then they don't do it. That can be normal. Happy to answer any questions, but I'll stop there. Yes.
Can you go over the eligibility, which trials?
Which trials are the, you're not asking about co-enrollment, are you?
No, I'm wondering,
No, no. I don't think we have that listed, but it's a good question. So all NCTN, in-core and lab sites are eligible.
So it doesn't have to be in
Any kind of treatment, they don't have to have been on a trial. I'm sorry.
Right. Oh, for those of you that are on the call, the question was about eligibility for this trial. Do they have to be on other therapeutic trials? Do they have to be on other ECOG-ACRIN trials? No, it's open across the NCTN, across the NCORE at lab sites. Any type of cancer, any stage is eligible except for basal cell skin carcinoma. Mike.
So John, did you consider some kind of control where you didn't have AYA? I guess you're not going to really be able to tell how forced versus fixed choice is for AYA compared to non-AYA.
Right, we won't. There's usually, I was telling somebody, there's always at least one thing that I wish I would have done differently once I get into a study. There might be more than one thing. With this one, you always learn about that. The funding opportunity was somewhat restrictive in terms of what we could do, right. In terms of other age ranges. It would certainly be feasible. I think the question or the concern there is if we go older, then we're losing potentially the ability to do computer adaptive tests because we would restrict it to only individuals that had the electronic access. And there's more of a digital divide as you start getting older.
Yes, yes. Well, it may not be too late at some point in the future if you just kind of study the same thing in a different cohort, even if it's not embedded in the same study, at least you'll have some sense of how different it is. Even a small cohort might give you some idea.
Right. Do you have a hypothesis?
Yeah,
I'm curious.
Yeah. Well, my hypothesis is that for much of this, it is not going to be that much different for AYAs than you'd be surprised that the AYAs may not be as special as you're expecting with respect to your hypothesis, particularly about fixed choice and forced choice. And then, and one other small thing I was wondering about, you know how like if you're doing a build your own burger, right? You could like build your own burger. That's, you know, you have choice, but then you could say, just give me the standard one too. Like you could choose to not
that's
have the
interesting.
burden of choice.
Right.
Do they have that option? Like if they just don't want to play, can they just go, I'm going fixed, I choose fixed? Or it's like, no, you must build your own burger.
Right. That's such a great idea. They don't have that option because they are randomized to choice or not. Now,
so it's forced choice.
That's right. Yeah. Now, when they go into choice, they could just we counterbalance. We randomize the order of presentation because they have that dashboard. And if it's like, if finances is first every time, and we know that finances, the data shows finances is in the top 5, well, we're kind of stacking the deck a little bit there. So we randomize the order every time. The closest thing that a participant could get possibly to, they get in the arm where they get to choose, and they're like, well, I don't want to choose, is they could look at that dashboard and they say, okay, that's fine. I'll just go on to the next one. And we don't know. We assume then that, right. Honestly, I need to check with the group at Brown to see, because I remembered having this conversation early on saying, do we know how much, because I want to know with what's been presented, how much did they change it in that ranking? Did they move it around? Did they engage with that? Because one of the options too, I was thinking about this as you were talking about the build your own burger, is there's this finite number of options too, right? Maybe it's easy if you've got 5 options and say, okay, pick your top 2.
Yes.
15, I was a little worried about that because that feels a little high. So is there like a sweet spot there of how many options are ideal and still support and encourage autonomy and patient engagement without this, gosh, let me just kind of move on. So,
It seems to
Very
me that the selection of the 5 most important domains at those time points will give you so much information, even if they didn't fill out the surveys.
Mhm.
I think nobody knows that trajectory or has ever looked. And so I think it's super exciting that you're asking them, but it'll be fascinating to see what
Right.
they choose. Yeah, if they choose the top 5 or something every time, that would, yeah, be too bad.
Hi, I'm Hildy Dillon. I'm the patient advocate on the lymphoma committee. This is really interesting. I just wonder, did you do or did Brown do any focus groups to, because you said you know that there's survey fatigue, or AYAs typically don't complete surveys, of other ways to capture this information with other types of tools, like there's you could do navigator interviews, you could do chatbots, you could do all kinds of different things to get a sense of where you might get the most participation, because the feasibility of people of the participants, whether or not they fill out the survey, might confound your ability to see the difference between the choice and the fixed. You want to be able to get them to provide the information and think about the information regardless of its platform or format. So that's just one idea, because if you do some focus groups, you might come to an idea of what might be more acceptable and utilized better. The other question I have is, you said in the beginning, I can't remember which slide it was, that you would evaluate the resources at the study sites that were available to the AYAs. Is there a reciprocal there, that if you identify certain scores of distress in different domains, will you be connected as a participant to the resources within your center?
Yeah, so, okay, great questions. Let me take the first one first. So we did not do focus groups as part of this study. In earlier research that I've done, we have done focus groups in post-treatment AYA survivors and individual semi-structured interviews about health-related quality of life, and using that tripartite framework of physical, emotional, social. And we actually added spiritual. City of Hope will use a 4th domain. We'll have spiritual in there. And so we use that as a starting point to start thinking about, all right, what are these most important aspects? And we had a separate study of over 500 AYAs where we did open-ended questions about, had them self-nominate, what are the things that are important? So that collectively, that data informed where we coalesced around those specific domains. What it didn't do, which I think is a great point that you're getting at, is modality preferences. And I'm thinking about, there's another study, NCI funded study that I was involved in, that's a post-treatment survivor intervention for psychological distress. And in the process of doing that, there was a clear push and a clear interest to making sure the intervention content was available by smartphone. We know from research literature, and I'll often say this during talks, I didn't mention it here, is AYAs prefer remotely delivered on-demand interventions. I will often say they want Netflix style interventions because it gives them the flexibility, it gives them the autonomy, it gives them, again, that on-demand component. So that led us this direction. You're right, though. Is there a group that we're somehow missing by kind of constraining this data capture in this particular way?
I was only asking because you mentioned it, that part the feasibility that you're testing, part of it is will the people that are invited to do this, will they complete the survey? So that's why I just kind of got stuck on, well, why a survey then, if there's an anticipation that may not be their preference, but maybe it will be.
Right.
You'll learn that, but yeah.
I think one of the things that you're getting at that will be enormously helpful is using that exploratory aim 3 about actionability, how they want that data used. That to me is particularly where those focus groups would be really useful, because that's all right. We can collect this data. There's many clinics that will, when you check in, they will give you an iPad to fill out your screening forms. Or I know I went to my dentist a couple of weeks ago and they gave me the link and I filled out the paper forms. Well, not the paper forms. I filled out the equivalent of the paper forms online on my smartphone. So there's an increasing way of managing it this way for workflow integration purposes. But again, to your point, I think we might be missing, all right, how can we tweak this as needed for the patient preferences?
Yeah, and the reason why I was asking about the resources is when I worked at the cancer support community, we did an intervention with several different cancer centers that was, we were measuring distress, but we also gave resources for distress. And people said that the resources were helpful, but then when we looked at clicks, they weren't clicking through on the resources. So it was there was this disconnect that, yeah, this is really helpful, but people weren't actually using them. And that would be, it would be really interesting to see if you actually, so I have psychosocial distress, and at my institution, you identify where they could go to get support or what office to call or whatever. Do they actually proactively take it to action? Because oftentimes there's that disconnect. So.
Right. That's again one of the next studies. Emily Haynes is a T32 postdoc fellow at Wake Forest. She was trained at UNC in Chapel Hill. She does work in implementation science. She's developed a needs assessment in AYA oncology and has specifically tailored this needs assessment so that based on those needs, it can then be triggered or linked to specific providers in those settings. Now she's testing that tool in comprehensive cancer centers, which is great. And it's a good opportunity, but then we still have all right, how do we get AYAs connected with some of the national level resources that Allison and others have mentioned? For this study, because it's not a treatment study, we provide a link to those resources if they have any questions, but we don't do any sort of direct follow-up. I think for us doing this through the NCORE and at that level of kind of scalability would have been challenging, would have significantly increased the burden on the sites.
All right. So we're at time. Thank you all for attending and for your attention. There's one last question in the chat. And so maybe you could address that and anyone who is interested can stay. And if you need to go, then thanks very much. So this is from Dr. Nappy. Thanks, Dr. Salzman. Looking forward to the results of this interesting study. Do you plan any specific analyses on the basis of different age ranges, tumor stages, treatments, and/or tumor diagnoses?
So great question. We hope. We hope. That's part of why we set it up for those most common cancers. It is a pilot feasibility trial. So responsibly from a statistical power standpoint, we're going to be somewhat limited for subgroup analysis, but we hope we have enough for those common cancer types, the heme malignancies, the breast cancer. At this rate, we may be able to do something with the colon cancer, look at it by sex differences. In a lot of the research that I do with AYs, we recognize that not only is there that disease heterogeneity, there's a lot of developmental heterogeneity. So I will often stratify recruitment by emerging adults, so 18 to 25-year-olds, as well as young adults, 26 to 39, because of the lifespan differences there. We want to be able to look at differences by emerging adults in young adults too. So, and I would also say on treatment versus post-treatment, that would be another area that we hope to look at.
All right.
We didn't get to it. My question